Thank you. Hello, everybody. Surgical people in this room probably know me. My name's Trish Duncan. I'm a consultant hepatobiliary surgeon, a primarily liver and biliary surgeon. I work in Cardiff at the University Hospital of Wales, and we are the regional centre for liver and biliary tract cancers for the whole of Wales, apart from North Wales. And I'd like to thank Helen and AMMF. Thank you very much for inviting me. I don't think, we may have had Welsh patients, but I don't think clinicians from Wales have been very well represented. And I have been the HPB lead for our unit for just around 12 months, so I am really grateful for this opportunity to come. So thank you very much. Just a couple of comments about Wales. I don't know if we've got any Welsh patients here or any people from Wales. Disclaimer, I am not Welsh, so you might have noticed from my accent, I am Scottish. But Wales is a beautiful country. It has lots of things that it is famous for. Many, many castles, beautiful countryside and the Pembrokeshire coast. A love of nation rugby and singing, common to my people in Scotland. And the eponymous Welsh dragon. And I would recommend the Pembrokeshire coast if you've not been there. It's good for both body and soul. On to other things. But NHS Wales is directly linked to NHS England, but we are a devolved nation. And nothing is quite the same. And I'll try and just in very simple terms to try and explain it. The NHS Wales, the local government, the Welsh government, gets a sum of money every year from the central government. And then the money it has, it decides what is going to go to the health service, and this is divided between 7 health boards, and those are our health boards. And within each health board are multiple hospitals, many, many hospitals. Betsy, North Wales, for tertiary services such as liver surgery, those patients go to Liverpool. And if you've ever travelled from North to South Wales or South to North Wales, you'll know why. It's very scenic, but it's very difficult to get there. It's 4 to 5 hours of travel. It would be very difficult for patients to get to us. And so this is a logistics thing that is sorted out by our fantastic colleagues in Liverpool. The population of Wales is about 3.1 million, about 700,000 people are in Betsy, and so our catchment population for the liver centre in Cardiff is about 2.5 million, ballpark. So it's a reasonable sized population, but as you can see, it's spread out amongst the bigger cities and then the rural areas, so it's quite diverse. What else can I tell you about Wales? We have 2 cancer centres, one in Cardiff and one in Swansea. Velindre, that I think Magda was speaking from yesterday, and Singleton in Swansea, and then there's outreach oncology centres as well, linked to some of the other hospitals, so patients can have oncology clinic appointments and some treatments. Okay, so it's not just the 2 hospitals, but a lot of the cancer care is delivered in those hospitals, and the surgical units are separate. Health in Wales. Now, there's lots of areas in the UK with social deprivation, but social deprivation overall in Wales is a little bit higher than UK average, with just over 1/5 of our population living in the most seriously deprived areas. There's also beautiful rural areas that have not got low social deprivation. There's areas outside of Cardiff and Cowbridge and so on that are relatively affluent. But we have some of the worst cancer outcomes in Europe. And as we know, people from the most deprived areas tend to have a higher incidence, not only a higher incidence of cancer, but also their chances of 5-year survival are much lower than patients who come from areas that have not got social deprivation or lower social deprivation. And that I see reflected in my patient groups. So I'm going to be really candid. And I'm not just going to present the good stuff, because we have got some problems in our health system in Wales, and I think we have some problems in delivering cancer care. And then when it gets to the HPB cancers, or what I think of as my cancers, and particularly cholangiocarcinoma, we have definitely got a lot of issues that could be improved. And I don't think it's just a problem in Wales, but there's some specifics. But I'm going to start, like all feedback, with some positive feedback and big up my team. So the liver unit's based in Cardiff, and as I said, apart from those patients from North Wales, we get referrals from every other hospital in the rest of Wales. That is my surgical colleagues, which is all the other gentlemen in that photograph, and then we have 4 clinical nurse specialists who are amazing. 2 of our clinical nurse specialists are Welsh speakers, and that is a huge support and comfort for our Welsh-speaking patients as well. Cardiff has a 24/7 interventional radiology for the whole region, so we take patients from West Wales for interventional vascular radiology, and obviously we also have a biliary interventional service, which is very experienced. We do have interventional endoscopy in the form of endoscopic ultrasound and cholangioscopy, or what some of you may know as SPY, but we're behind the curve, and I know that we're behind the curve because when I pitched up as a fellow back in 2015, it wasn't available at any site in South Wales. And having trained in England and at the HPB centres in England, it was already relatively advanced and standard when I was there. And so we're catching up, but I think the experience throughout my region is not quite there. We've also got, in addition to that, the other health specialists. I've not mentioned the whole team, but our pathologists and acute oncology. So Velindre, our local cancer hospital, is a separate hospital. It's not ideal because sometimes you do need complex conversations with your oncologists, and it's lovely to be able to do it face-to-face or do it easily, especially when a patient who is under the care of oncology pitches up as an emergency and you have to make some difficult decisions. So we have a halfway house. We have an acute oncology nursing group that are on site who are linked to Velindre, are linked to our local oncologists. But obviously, it's only for Cardiff and Vale. It doesn't link into Singleton and so on. So a lot of emails and phone calls and so on still go on. I didn't put a lot about surgery, but just so you know what we do for cholangiocarcinoma, I haven't put it in a slide, but all our patients will get CT, MRI and PET for staging unless they've got advanced metastatic disease at presentation. We try our surgical practice, I think John Primrose mentioned earlier, is myself and my very established colleague, Mr. Kumar. We try and make sure that we do all the hilar cholangio as a pair, so 2 consultant operating. We make some very detailed decisions about borderline operable decisions, and we try and make sure we give as much opportunity to as many patients to get to surgery as possible. But I'm going to just talk for a second before I carry on about equity, because, and I think this is not just a Welsh problem, but if you come through the door in Cardiff, and one of my colleagues who's on for general surgery pitches up with a patient who may have a hilar cholangiocarcinoma, they will give me a ring or one of my colleagues a ring, and they will get worked up acutely. So I will see them, we'll assess them, we'll get a CT, an MRI, order a PET, try and get them through MDT, try and get biliary drainage. And that will happen if you pitch up at my door, hopefully, in a relatively short space of time. But if you are a patient, let's say, way over in West Wales, in Carmarthen, and you come through the doors of your local DGH, you may come in under a gastroenterologist, or you may come in under general surgery. And then you may get a CT scan, and then somebody will look at the CT scan, and then they might think about doing, even though there's guidelines, they might think about doing an MRI, but that MRI may take some time. And then somebody might want to do an ERCP, and by the time they've got to the point where they've had thinking about a cholangiocarcinoma and thinking about referring to us, it's not uncommon that 2, 3, 4 weeks may have passed, another week to get to MDT, another week to get to see us in clinic. So you can see that there is inequity in the system just by where you present, and if you present in a district general hospital rather than at a specialist centre. And I think there is a bit of this around the country. There may be areas that are better than others. So what's good? We're 4.5 surgeons. I count one of my colleagues as a half surgeon because he's also a full-time military surgeon. And when the world is a little bit wobbly, such it is right now, he's often deployed, and he has actually just been deployed for 6 months, which is quite hard for us because we lose a whole person. And a little bit about funding. So NHS Wales funding is very, very different to England. And I know that there are, a tariff system is not the end-all and be-all. But what it does mean is that a lump of money is given to each health board, and specialist services such as HPB, the funding for those services is not a funding for a service. There is an entity called the JCC. It is made up of members of each individual health board, of managerial and clinical, and they decide how much money you get for a specialised service. So what we get paid for doing a number of liver resections. And it's sort of a tariff, but it's a kind of vague one. And what it means is that it is really difficult. If you double the amount of patients that you're seeing, that money does not necessarily follow the patient. So it can be really difficult to develop your service to respond to increasing demands. And if you ask those of you that met one of my clinical nurse specialists at the start of the week, will say that I had Shan, who was the first CNS for the patients, from when she started to when we appointed a second CNS, the number of patients that she was expected to help and support had tripled. And she was on her own. So you can see how the pressure on those services can be quite significant. I would love to give you some data about cholangiocarcinoma in Wales. I do know that the incidence, as reported everywhere else, is increasing. I also know that the mortality is increasing. But I can't actually give you any more data than that, because Welsh Government does not mandate that we report it. In fact, cholangiocarcinoma is not on Welsh Government's radar at all. And despite much, shall I say harassment, is that fair? From myself, my team, and looking at our cancer network and complaining, data is not collected by tumour site, so it's not reported. And cholangiocarcinoma, every other cancer that you pretty much can get in Wales has got an optimal national pathway. Those are the things that we recommend to try and get patients from diagnostics to treatment within 62 days. And I'm going to show you the full list. I think I just copied and pasted it. You can see there's all sorts of stuff on there. So hepatocellular carcinoma is there, gynae tumours, vague symptoms has got a pathway. If you look at upper gastrointestinal, there's gastric, esophageal, pancreas, no cholangiocarcinoma. So if we don't have an accepted pathway for Wales, how are we expected to try and, get patients diagnosed and treated quickly? So I think this is a huge injustice. I've been banging on about it for quite some time. And I think Helen knows I'm really keen that we go to the Senedd now that we've had an election and we've got a new health minister, because this needs to change. We need to understand what is happening with cholangiocarcinoma in our population. We need to collect that data robustly so we can plan services and improve things for patients, because data is really, really helpful for that. I'll show you what is reported. Public Health Wales has reported. We had a look at this. Many thanks to Paul from AMMF. I'm not sure he's here, but we looked at what Public Health Wales has actually reported. So first of all, it said that for 2020-2022, the incidence was 3.3 per 100,000, which seemed a bit low compared to Scotland and what was at that point predicted for England. Our mortality looked about 5.5 per 100,000 person years, which is probably right for our population size. So the mortality may be getting picked up. But if you looked at what's happened if you compare data from 2002 to 2004 versus the 2020-2022 data, there's a great big red flag for me, is it says our incidence in Wales has increased by 22% in that time. But the mortality has increased by 108%. So those figures don't make sense to me, and what it says to me is that we're not really picking up the incidence of cholangiocarcinoma in Wales, and that our Welsh Cancer Intelligence Surveillance Unit we're missing cases. They're not being documented, and so that's bad. I am really thankful to Matt, who presented earlier, so I don't have to go into this, who showed that there is some discrepancy between what molecular testing we can get in Wales and parts of the country. And that, even though we seem to be doing reasonably well, I have to say, actually, HER2 testing is only just been approved in Wales, and it's only been approved because NICE has now said that it should be. So there is that link with NHS England that we can get whatever NICE says that we should get, but we can't get any more. And I think Matt demonstrated nicely that it does look like there is going to be a gap going forward to what you can get in NHS England. And that is something that concerns me, because I would want all my patients to have the best options available from the point of view of treatment. We have the All Wales Medical Genomics Service, or AWMGS, and what they've told us is that they have some capacity constraints, but they're targeting expansion in what they can test. They can take requests from private consultants, but they don't undertake any private testing. So if a patient wants to get something that isn't offered because they want to, get more information or get another opinion, they have to go and pay for that and have that done elsewhere themselves, which is fine if you can afford to do that. It's not fine. And for trials, if patients are trying to get into trials, that they expect the trial centres to perform the analysis. But the path labs will provide the blocks and things. So, for example, for Professor Bridgewater's trial and stuff, they will provide the pathology blocks. We did have a little workaround, is that if you requested your molecular testing as a possible primary of unknown origin or a cup with a cholangio, that you could get the extra tests. Now it doesn't look like we'll need to do that sneaky workaround. Trials. Equity of access for patients in Wales. I know that particularly Prof Bridgewater says that patients will travel to get into trials, and that's right. I think people will travel, but I do get patients complaining about having to come 30 miles up the M4 to get their surgery. But as I said, we work in an area with quite high social deprivation, and not everybody can afford to travel or has the family support that you need around that. And I have spoken to relatives of patients from Wales who have been on treatment at trial centres outside of Wales, and even for those people that are comfortably off and can support it, don't have any doubt that it's hard. And what would be amazing is if we could, and I know this is very, very hard because research funding is very, very tight, but UK trials where we could enrol locally to our oncology centres would be amazing, I think, for lots of patients. In summary, and I'm hopefully coming in on time, cholangiocarcinoma, for us to improve what we can do for our patients in Wales, we've got to recognise it, we've got to make awareness in government and amongst my cancer colleagues as well, and my surgical colleagues, wherever these patients are presenting. So it's recognised and it's well reported, because we need to know what we're doing for our patient population. And cholangiocarcinoma patients should have a national optimal pathway in keeping with all the other cancer groups that have. I would like for Welsh patients to have their HPV specialist centre recognised so that they know that we're here and that we want to support them. I would like equity of access for Welsh patients to molecular testing and trials. And if I could, I would like it close to home, but we'll take what we can get. And I'd like to finish on a personal note, because surgeons have a reputation. Apparently, I don't have a normal surgical personality, but I'm not sure about that. Diolch is thank you in Welsh, so I've picked up a few words in Welsh. This is my son, who knows that I'm going to put a picture up of him and sulks all the time, and I've done it since he was small. I think the patient experience and the relative experience is very difficult. And sometimes I think, and I know that patients and families feel like we're not on their sides, and decisions are made far away. And I think this is just a note of caution for over-centralisation, that we're making decisions about people that we sometimes have never met. And sometimes the people explaining that to them have not got a depth of knowledge. And I think we have to be a little bit careful about that, because there are a lot of nuanced reasons why somebody may not get to surgery and so on. And I think it's on us to explain that to people. But why my son is up there is that when we don't have other benchmarks or we're struggling to get data and compare, when I think about my cancer patients, I look at my family and the people that I care about. And most of us have been personally touched by cancer in some way. I have. And I know a lot of my colleagues have. And I think, would this be good enough? Would this be good enough if it was my person? And I find us lacking. So that's how I'd like to leave it.